I'd like to thank the Alzheimer Society of British Columbia for inviting me to give this webinar and share my research with this community. So as it says on the slide, my name is Ashleigh Parker, and I'm a PhD student. And I'm a PhD student in the clinical psychology program, specializing in neuropsychology at the University of Victoria. And I'm supervised by the wonderful Dr. Jody Gawryluk, who has provided me with continued support during my master's degree and will continue to provide her mentorship throughout my doctoral degree. Just a reminder to everyone in the webinar who is viewing, if you can make sure that your camera is off and that your microphone is muted, that will help everyone else to just be listening to the presentation that I'm giving. So make sure that those two things are off. Okay, so to give a face to my name and my voice, that is right here. So
I would either do event supplies or other.
Okay. Oh, so can we just please make sure that we are muted if we are viewing the webinar? So I'm a PhD student at UVic, and my connection to the Alzheimer Society is through their Research Reward program, where the Alzheimer Society will be funding my doctoral research. So a little bit about me is that I was born and raised in West Kelowna, British Columbia, where I was lucky enough to stay in my hometown while completing my Bachelor of Science honors degree in psychology at UBC Okanagan. So my interest in researching and working with older adults and those with neurodegenerative diseases began quite early, where in my last year of high school, I worked as a recreation volunteer at a senior living community in my hometown. And this ended up lasting 5 years, where I volunteered throughout my entire bachelor's degree. As time went on, I became more and more passionate working with these individuals and their families, and I ultimately wanted to focus my career on having a more involved role with these individuals in the context as a clinical psychologist. So since I am only in my first year of my doctoral degree, I'm only in the early stages of beginning my doctoral research. So instead of speaking about my future plans for research, I'm going to share with you the research I conducted as part of my master's degree. So before jumping into my research project, I want to set the stage and speak a little about some statistics of Alzheimer's disease and dementia in Canada, and why it's important for researchers to be focusing on dementia research. For the first time in Canadian history, the 2016 census revealed that the number of individuals over the age of 65 surpassed the number of those under age 14. It's predicted that by 2031, nearly 1 in 4 Canadians will be over the age of 65. In light of these statistics, Canada's population is rapidly aging, and as one ages, there are risks of developing certain diseases such as Alzheimer's disease. After the age of 65, the risk of developing Alzheimer's disease doubles approximately every 5 years. So the older you get, the higher the risk. In fact, in those aged 65 or older, 1 in 20 Canadians have Alzheimer's disease, and this risk drastically increases where at age 85, approximately 1 in 4 Canadians have Alzheimer's disease. So as discussed in the last slide, increased age leads to an increased risk of developing Alzheimer's disease. Alzheimer's disease makes up approximately 70% of all dementia cases, and the term dementia refers to a general decline in overall mental abilities and could be caused by a number of different conditions or different diseases. Alzheimer's disease is characterized by memory impairment and underlying neuropathology, which can include beta amyloid plaques, neurofibrillary tangles, and neurodegeneration. There is a late diagnosis for Alzheimer's disease where an individual is not usually diagnosed until later stages where irreversible neurodegeneration has already occurred. Currently, there is no cure for this disease. Therefore, earlier identification of individuals who are at a higher risk of developing Alzheimer's disease is necessary. So here in this figure, it's showing us the trajectory of cognitive decline in normal aging with that sort of straight purple arrow. as well as the trajectory of cognitive decline in non-normal aging, such as what we would expect to see in dementia. Cognitive decline is shown on the vertical axis, where lower points on this graph represent more significant levels of cognitive decline, while the horizontal axis is showing us time over years. Down on the bottom right is what is considered the most severe of cognitive decline because someone in these phases would show levels of cognitive impairment that would interfere with their ability to carry out their everyday activities. If we take a step to the left, we would be at mild cognitive impairment, or also known as MCI. In this phase, the individual may be experiencing cognitive changes that are of concern to themselves and or their loved ones. In mild cognitive impairment, one or more cognitive domains are significantly impaired, but their abilities to carry out daily activities is relatively preserved. Although this is the first stage where detectable differences in cognition can be found, as on cognitive testing, there is already irreversible damage to the brain. So it makes sense for us to start looking a little bit earlier at this preclinical stage known as subjective cognitive decline, also known as SCD. So here in this phase, the individual experiencing the decline may notice differences in their own cognition, but this decline would not be detectable on cognitive testing, meaning that someone in this phase could still perform within the normal range of scores on these cognitive tests, even though they're noticing a problem in their own cognition. So in 2014, a working group called the Subjective Cognitive Decline Initiative operationalized the term subjective cognitive decline, aiming to create a definition and reach a consensus of terminology and create a conceptual framework for researching subjective cognitive decline. The research criteria for subjective cognitive decline requires the individual to one, have a self-experienced decline in their cognitive capacity in comparison to their previously normal status, and two, perform within normal limits on standardized cognitive tests that are adjusted for their own age, gender, and level of education. So it's important to note that both of these criteria must be present to be considered to have subjective cognitive decline. An individual would not be considered to have subjective cognitive decline if they are diagnosed with mild cognitive impairment, prodromal Alzheimer's disease, or another form of dementia. They would also not be considered to have subjective cognitive decline if the reason for their decline in cognition could be better explained by a different psychiatric disorder, a different neurological disease apart from Alzheimer's disease, a different medical disorder from side effects of a medication, or from substance abuse. So before getting too ahead of myself, I want to communicate that seeing some decline in cognitive abilities as you age is completely normal. I find that when I explain my research to others or even to my own family members, I'll always hear someone say, "Oh, well, I think I have subjective cognitive decline," or "I think there's a problem with my memory. You should research me." And in response to these sort of comments I get, I try to say something about how the normal aging process is associated with some declines in certain cognitive abilities, which could include slower problem solving, slower processing or perceptual speed, and declines in certain forms of memory. However, some skills still remain relatively constant, like your own verbal abilities. Also, many different things can impair one's thinking abilities, including fatigue, stress, feelings of anxiety, feelings of depression. And I definitely know from being a graduate student how being tired can impair my own ability to think properly. So, how do we distinguish symptoms as part of normal aging from something bigger like dementia? Well, some parts of normal aging could include symptoms of not being able to remember details of a conversation or an event that took place about a year ago, not being able to remember the name of an acquaintance or someone you just met, sometimes forgetting items or things or appointments, sometimes, occasionally having difficulty finding words when you're speaking, and that you are worried about your own memory, but maybe your relatives or a significant other is not. More serious types of complaints could include not being able to recall details of recent events or conversations, so something that just happened recently. If you're not able to recognize or you don't know the names of your family members, that's something more serious. Or if you're consistently or forgetting things or events quite often, if you have frequent pauses or you're substituting different words in when you're trying to think of words to say in conversations. And another is that your relatives are concerned about your memory, but you aren't really aware of having any problems. So all of these examples could cause someone to feel some subtle differences in their cognitive functioning. And subjective cognitive decline does not refer to someone occasionally misplacing their keys or not knowing where their cell phone is, or forgetting the name of someone they just met. Subjective cognitive decline refers to something more serious with some more serious issues or symptoms, like those we saw in the right-hand column, opposed to the ones on the left. So returning back to this definition of SCD created by this research group, where an individual, one, has a self-experienced decline in their cognitive capacity compared to their previously normal state, and that they have normal performance on standardized cognitive tests. This research group also believes that this preclinical stage of Alzheimer's disease is likely to have detectable biomarkers. But what is a biomarker? A biomarker is a measurable biological characteristic that can be identified in vivo or while you are alive, and it's indicative of risk or presence of a certain disease. So one way that we can measure biomarkers is through magnetic resonance imaging, also known as MRI, which is the focus of my research. So MRI is an ideal technique for biomarker detection because it's non-invasive, does not expose the individual to any radiation, is easily repeatable, widely available, and capable of producing high-resolution images of the body, including images of the brain, which is what I am interested in. MRI is also capable of acquiring different types of data, all on the same machine. So from just one MRI machine, I'm able to get structural MRI images as well as functional MRI images. And I use both of these modalities in my research. So when we're thinking of structural MRI, that can be thought of as taking a snapshot or a picture of the brain, while functional MRI can be thought of as taking a video of the brain. So in my study, the data I used was collected from the Alzheimer's Disease Neuroimaging Initiative, also known as ADNI. Each group had 23 individuals with the same number of males and females, and the groups were not significantly different from each other in age or level of education. So these groups were exactly the same, where both groups were comprised of healthy individuals with normal scores on cognitive tests. There was only one difference between these two groups, which was that those in the SCD group had reported a self-experienced decline in their cognition. So my first research question was, are there differences in brain tissue density between those with subjective cognitive decline and healthy controls? I had hypothesized that those with subjective cognitive decline would show decreased brain tissue density compared to healthy controls. So for this first research question, we expected to find decreased gray matter volume in those with SCD relative to healthy controls. But instead, we did not find any differences in gray matter volume between these two groups. This result suggests that individuals who experience subjective cognitive decline show similarities in their brain structure compared to healthy individuals who do not report a decline in their cognitive abilities. So, the result of no difference in brain tissue density across groups is consistent with past studies. However, other studies have found individuals with SCD to show decreased brain tissue density compared to healthy controls. Reasons for these conflicting findings may be due to methodological differences across the studies, particularly with regards to sample characteristics, such as significant difference in APOE E4 status across groups, where APOE E4 is known as a risk factor gene because it increases a person's risk of developing the Alzheimer's disease. Other differences across studies included participants experiencing elevated levels of depression. Further, multiple studies that found significant levels of atrophy in different brain regions may be attributed to subjective cognitive decline participants, all being collected from memory clinics rather than community samples. And we can hypothesize that individuals with subjective cognitive decline who are going to memory clinics are maybe experiencing a later form of subjective cognitive decline or worse symptoms. Since they are so concerned, they are presenting at memory clinics or asking doctors for help. Finally, some of these studies only asked one or two questions to distinguish individuals with subjective cognitive decline from healthy controls, which included something like, have you experienced a decline in your cognitive abilities? And are you worried about this? It would be helpful to have a more sophisticated method of identifying subjective cognitive decline to ensure that those included in research studies are in fact experiencing subjective cognitive decline, opposed to a different ailment causing cognitive impairment. For the second research question, we asked, are there differences in fMRI functional connectivity between those with subjective cognitive decline and healthy controls? We hypothesized that those with subjective cognitive decline would show increased functional connectivity compared to healthy controls. Now, before I jump into the results of functional connectivity, I want to break down what that term means. So, in this study, we are using functional MRI to take a video of the brain to identify functional connectivity. And we're measuring functional connectivity by looking at spontaneous fluctuations in the blood oxygen level dependent signal or bold signal in the brain. I'm going to break this up a little bit more too. So essentially, the more active an area of the brain is, the more you will see oxygenated blood in that particular area. Opposite, the less active an area of the brain is, would result in less oxygenated blood in that area. So, if I were to break that down even just a little bit more, the most important thing to think of is increased activity represents more oxygenated blood, and decreased activity in the brain represents less oxygenated blood in certain areas. I know that can be a little bit confusing. So, this is allowing us to monitor which parts of the brain are used during different tasks based on the level of oxygenated blood in different areas. And we can do this during tasks or by asking the person in the MRI just to lay still and not think of anything in particular. And this way, we're able to look at that oxygenated blood in different areas of the brain. So if we're looking at this slide, we would be interested in the amount of oxygenated blood in brain region A versus brain region B occurring at the same time while laying inside the scanner. So using functional MRI in this way helps us to identify areas of increased or decreased levels of oxygenated blood, or looking at the increased or decreased levels of activity, which in turn can be used to identify abnormal brain activation patterns, which can be seen in neurodegenerative diseases, one of which could be Alzheimer's disease. So now if we can try and remember everything that I just said, which I know was complicated, um, results that we found for this part of the study was using resting state functional connectivity, we found there to be both increased and decreased activation in those with subjective cognitive decline compared to healthy controls. You may notice that I have labeled the right and left on opposite sides in the left top hand corner of the figure, and I promise that I do know my right from my left. And when presenting neuroimaging findings, it's standard for these directions to be switched. So when we're looking at this image, we found that individuals with subjective cognitive decline show functional differences in their brain compared to healthy individuals who do not report a decline in their cognitive abilities. So when we're looking at this slide, the red is telling us that there's increased functional connectivity in certain areas, and the blue is that there is decreased functional connectivity in these areas in those with subjective cognitive decline compared to healthy controls. So a theory for the cause of these differences in functional connectivity may be attributed to a compensatory mechanism that is enacted when there is a failure of proper functioning within different areas of the brain. It has been theorized that decreases in functional connectivity seen in later stages of Alzheimer's disease may be attributed in these later stages of Alzheimer's disease, may be preceded by past evidence of increased functional connectivity that seemed to be a compensatory mechanism at one point. So within this theoretical context, it is possible that regions with decreased connectivity represent areas throughout the brain that are no longer able to compensate. So as a brief summary, this study revealed changes in brain function, but not structure, in those with subjective cognitive decline. This tells us that there are functional changes in the brain that are detectable prior to measurable decline on neuropsychological assessments or cognitive tests in those with SCD, or subjective cognitive decline. This study represents a crucial step in characterizing subjective cognitive decline, which is a group recognized to be at an increased risk for developing Alzheimer's disease. In the future, there needs to be more studies of biomarkers in subjective cognitive decline so that disease-delaying interventions can be implemented at the earliest time point to reduce the devastating effects of this neurodegenerative disorder. So I'd like to thank the Canadian Institute of Health Research, who funded my master's research, the Alzheimer's Disease Neuroimaging Initiative, who collected the data that I utilized in this project, the Alzheimer Society of British Columbia for inviting me to share my research, and last but not least, to all of you who have tuned in to learn more about my research. So thank you all very much, and maybe we have some time for questions. Okay, so let's see. I'm just looking at the questions. So does everyone see like my screen right now if I'm looking? So one of the questions I'm seeing here is, at what point does or should a doctor recommend an MRI? It concerns me that it isn't often used due to cost. Is this changing? So something that I would say about MRI is that unfortunately MRI is not being utilized as much clinically as it is in research. So we're actually getting a lot more use of identifying Alzheimer's disease or different diseases in research using MRI. And the reason for this is mainly because people who in clinic, so when you're working in a hospital and you're trying to get a diagnosis, we're worried about one individual, and does that person have Alzheimer's disease, or do they have something else going on with their brain? What I would say to that is that when we're doing research, when I was showing the actual pictures like this isn't just one person. What we're seeing here is all 23 individuals averaged onto one single brain. Some other barriers to using MRI clinically has to do with the fact of, one, it's expensive, two, There is some special training to process this data, and when health systems are overworked or overtasked, it's hard to spend time to sit down and take the time to pre-process this data. So more information needs to be researched, or we need to find out more things of how we can use this for an individual person instead of a group of people. Okay, so one of the questions. The second question I'm seeing here is, what do you suggest we advise people to do if they report to us? Um, Sorry, I was reading a different comment. What do you suggest we advise to people if they do report to us that they have symptoms but have normal testing results, healthy brain practice, and regular testing? So I think that when people actually come to you in an office, or if they're coming to a health provider and saying that they're having this problem, something that has been used, and not so much in BC, but in Ontario especially, at Baycrest, they have used different sorts of cognitive screeners. So what that means is that when we're looking at, I think what they've done with their research is that they've actually have like an app on their phone, or on like everybody's phones, where you can do different cognitive tests or different questions and see how you're doing. So if the app notice that you're trending down, or that you're trending in a direction of having, I guess, Alzheimer's disease, or just showing decreased functioning, that's when you would want to maybe go to like a memory clinic, or you'd want to follow that person more. So if you're getting someone coming to a clinic saying, I'm having these problems, instead of being like, hey, come back in a year, maybe have more frequent appointments, have different ways of measuring how they're doing, so you're able to track those differences. Sorry for the long-winded answer. I'm thinking on my feet a little bit here, but I can also trying to think if maybe we can somehow get my email out to people. If you do have other questions, I could direct you in different areas. It's hard for me to speak about stuff just off the top of my head, but I'm very happy to, here, I'll just enter it here actually. I forgot about the chat for everyone. So that's my email for you, Vic. So if you do want to follow up with me about anything that I've said or want to learn more, please feel free to email me, and I'll try my best to point you in the right direction. Or if something I said didn't make sense, like trying to explain that phone app, that's something you can also email me about. And yeah, if anyone has any other questions, please type them into the chat. I cannot off the top of my head. I can look. And it might only be in like beta testing right now. I know that it's pretty new. And if you're ever looking at getting like doing, I know that there's other things like Brain Age or some other sorts of apps where it's like improve your brain by doing these games. And you always want to make sure that what you're looking at or something you're trying to do is research. It does show evidence in research. And it's not just that you're getting better at specific types of games or different abilities. So I'm still looking for the app. Okay, so right now I don't see I don't see the name of the app, and I'm feeling that that is actually, um, this might just be for people who are patients at Baycrest in Ontario. I think that there's also been work on the island and with UBC and with UVic about creating like a cognitive health screener to be more accessible to people in the community. And I'm positive once that is up and running, that would be information that you could get from the Alzheimer Society website. Okay. Um, Yeah, and if you're unable to type into the chat to answer or to ask any questions, you can also unmute yourself and verbally ask your question as well. Okay, well, that's all that I think we have for right now. If you have any questions, of course, forward them to the Alzheimer Society or to me if you would like to. And thank you for listening.